Hello students, myself Aleena Anilkumar, Assistant Professor, Department of Anaesthesia Technology, School of Allied Health Science, Salem. Today I am here to take a session on spinal anesthesia. Before going to the session, I would like to give a brief description about types of anesthesia. We have general anesthesia, regional anesthesia and local anesthesia. Under regional anesthesia, we have central neuraxial block and peripheral neuraxial block. Under central neuraxial block, we have spinal anesthesia, epidural anesthesia and caudal anesthesia. The spinal anesthesia comes under central neuraxial block. Now we can look at the course content, definition, indication, contraindication, types of spinal needle, drugs, procedure and its complication. So coming to the main topic, spinal anesthesia. It's a type of regional anesthesia in which a local anesthetics is injected to the subarachnoid space, that means intrathecal space of spinal canal. It is usually indicated in lower abdominal surgeries. So it produces a temporary loss of sensation and motor block. Now we can look at the space. Here we can see the spinal cord. We know that we have 33 vertebrae. In that we are injecting spinal drug into the lumbar vertebrae between the L3 and L4. The normal spacing of spinal anesthesia is L3 and L4. So here we can see that the intrathecal space, that means or subarachnoid space between the pia mater and arachnoid mater. Here we will inject our local anesthesia drugs. So next we can look into the structures encountered during spinal anesthesia. That means which all structures we need to encounter to inject or insert the needle. So here we can see that skin, the outermost surface is skin, subcutaneous fat, supraspinous ligament, infraspinous ligament, ligamentum flavum, dura arachnoid, and this here it is a spinal space. Next, the indication of spinal anesthesia: lower abdominal surgery, pelvic surgery, perineal surgery, urological surgeries and lower limb surgeries. Contraindication: patient refusal, infection at the site, severe hypovolemia or shock, raised intracranial pressure, bleeding disorder or patient under anticoagulant therapy, severe spine deformity or allergic to local anesthetic. So coming to the main topic, spinal needle. Spinal needle is the one of the main content in spinal anesthesia or spinal anesthesia topic. So here we have two types of spinal needles, dura cutting needle and dura separating needle. Dura cutting needles are Quincke, Babcock, Greene and Pitkin. Here we can see the figure. This is Quincke, this is Pitkin and this is Greene. Here we can see the figures. As the name itself it is there, dura cutting needles will cut the dural fibers and enters to the space. So it will cause more damage to the dural fibers, hence the chance of PDPH. PDPH means post-dural puncture headache is more in this needle. And we have another type of needle, dura separating needle. As the name itself it is there, dura separating needle separates the dural fibers and it enters to the space. It has a special tip, pencil point tip. So it separates the dural fibers. So there is a less incidence of PDPH, but it is not used commonly because it is little expensive and also technically it is difficult. Dura cutting needles, for example Quincke. Quincke is the most commonly used in spinal needle because it is cheaper. Also the technically it is little cheaper than comparing to dura separating needle. So the dura cutting needle Quincke is color coded according to their gauge. Here we can see that 27 grey, 25 orange, 23 blue, 22 black, 21 green, 20 yellow and 18 pink. Commonly used gauges for adults are 25 orange, 26 brown, here it is not there, and 27 grey, 23 blue. So coming to the drugs used in spinal anesthesia. Mainly local anesthesia drugs are used for spinal anesthesia. Most commonly used is bupivacaine, 0.5% bupivacaine added with 8% of dextrose to make it heavy. So it is known as hyperbaric bupivacaine or Anavin heavy. Here we can see the image of Anavin heavy. Why we are making it heavy means the drug should be heavier than our CSF. The specific gravity of the drug, we should increase the specific gravity of the drug than the CSF fluid because the drug should be settled down below the abdomen because or below the umbilical level because it should not move upward. If it is moved upward, it can cause serious conditions like high spinal, total spinal and all. So it should be settled down. So that's why we are making it heavier by adding 8% of dextrose. Another drug we are giving lignocaine 2% 2 ml. Here it is. Why we are giving lignocaine? Because we are giving lignocaine for skin infiltration. 2% lignocaine, 2 ml is given for skin infiltration. Why? Because the spinal needle is very thick and it will be painful while injecting. So to numb the local area, we are giving 2% lignocaine, 2 ml. We are using adjuvant drugs mixed with the local anesthetic drug. Why we are adding adjuvant means to increase the time duration and effectiveness of spinal anesthesia. The commonly using adjuvants are fentanyl, buprenorphine, morphine and clonidine. Coming to the procedure. Equipment used. First, the main thing, spinal set we need. Inside the spinal set, we have Hall towel, galley cup, sponge holder, gauze piece. Other than spinal set, we have to keep ready spinal needle. As I told you before, there are 2 types of spinal needle, most commonly used in Twinkie, dura cutting needle. Spinal needle, hypodermic needle, 26 1.5 hypodermic needle, drugs, betadine and spirit. Coming to the procedure, like before the patient enters to the OT, we have to keep ready all the equipments. After patient reaches the OT, lie down the patient, make the patient comfortable and connect all basic monitors. Basic monitors like SpO2, BP is mandatory and position the patient. Normally, we have 2 positions for spinal anesthesia. One is sitting position and another one is lateral position. In sitting position, the patient should sit. The patient will sit on the table and legs will be extended and the patient has to bend forward and make the back curve like this. We should support the head and shoulder of the patient and this position helps to open the space between the vertebra and making the incision of needle easier. Here we can see the vertebrae, lumbar vertebrae. So in lateral position, the patient lies on one side and knees are drawn upward, up towards the chest and neck is flexed like this. Here we can see that a curve is formed and the back is formed like a curve and we can see that the vertebrae. So this position also help to open the space. These are the 2 spaces we are used to give spinal anesthesia. So after positioning the patient, cleaning and draping. Cleaning and draping means cleaning with the betadine. Like we have to paint the patient with betadine and clean with the spirit. And after cleaning, have to place a Hall towel to the patient. And after that, we have to find the approach. Approach means how we are inserting our spinal needle to the patient. Here we have 3 approaches: midline, paramedian and Taylor's approach. Most commonly used is midline. So what is midline approach? Midline approach means the needle is inserted the center of the back between 2 spinous processes. Here we can see that between 2 spinous processes, the needle is inserted center. This is midline approach. And other one is paramedian approach. In paramedian approach, you can see that slightly lateral to the midline approach. The needle is inserted slightly lateral to the paramedian approach. So after confirming the approach, we have to give local infiltration of lignocaine 2%, 2 ml with the help of 26 1.5 normal needle. After that, we have to check for the space and insert the spinal needle. After inserting the spinal needle, remove the stellate and look for the free flow of CSF. That means like free flow of CSF means the CSF should flow without any blood stain. Okay, we can confirm the pace by looking the free flow of CSF. And after looking the CSF flow, we can inject spinal drug. 2 to 3 ml of bupivacaine we can inject to the space with or without adjuvant. And suddenly after the injection, make the patient into supine, check for the BP. If the BP is normal, then check for the confirmation of block. We can ask the patient to lift the leg. If he or she is not able to lift the leg and if he or she is not able to feel the pain, then we can confirm the block. So coming to the last topic, complications. What are the complications which can occur during or after spinal anesthesia? Here, total spinal or high spinal, that is the most important complication. It's very rare but severe. Hypotension, most common. Shivering, urinary retention, that is also most common. Bradycardia, nausea, vomiting, difficult in phonation. Difficult in phonation means difficult to speak due to high spinal. Then PDPH. PDPH is the most common complication in spinal anesthesia. That means post-dural puncture headache. As I told you before, due to that spinal needle, dura cutting needle, it cuts the dural fibers. Therefore, the chance of PDPH is very high. So the patients after using dura cutting needle is they're complaining of PDPH. So it is the most common complication. Next, nerve injury, meningitis, failed spinal and pain at the site of injection. As I told you before, in the needle is very painful. While inserting, it will be little painful. So after the surgery, the patient might feel pain at the site of injection. So we can summarize the class once. We have 3 types of anesthesia. Spinal anesthesia will come under regional anesthesia under central neuraxial block. So spinal anesthesia is a type of regional anesthesia in which a local anesthesia drug is injected to the subarachnoid space. Okay, it is usually indicated in lower abdominal surgeries. Okay, for example, urological surgery, LSES, orthosurgeries and all. So usually given in L3, L4 region. Okay, L3, L4 vertebra. The spacing are inside the subarachnoid space. Okay. Indication, as I told you before, all lower abdominal surgeries, and contraindications are patient refusal, infection at the site, or spine deformity, or is allergic to the local anesthesia drug. These all patient, or the patient having this condition, we can exclude it, or we can change the anesthesia procedure. So the main topic is spinal needle. As I told you before, we have 2 types of spinal needle, dura cutting and dura separating. Here we can see that why the dura cutting needle causes PDPH. Here we can see that the tear caused by the dura cutting needle and the tear caused by the dura separating needle. Here we can see the difference. So this dura cutting needle will affect the dural fibers very much. That's why we are getting PDPH very badly after spinal anesthesia. So the example for dura cutting needle are Quincke, Babcock, Greene and Pitkin. In dura separating needle, the main point is it is pencil point, so it just separates the dural fibers, therefore less incidence of PDPH and less damage to the dural fibers. Examples are Whitaker and Sporte. Next important topic is color coding of spinal needle. That means most commonly using spinal needle is Quincke needle, that is dura cutting needle. So these Quincke needle are color coded according to the gauge. Like commonly used Quincke needles are 25 orange, 23 blue, 26 brown and 27 grey for adult. Next, drugs. Drugs mainly bupivacaine, 0.5% bupivacaine plus we are adding 8% dextrose to make it hyperbaric. Why? Because to make the solution heavier than CSF. After that, another drug is lignocaine 2% for infiltration and adjuvants. Adjuvants mainly opioids. Then equipments we needed, spinal set, spinal needle, hypodermic needle, drugs, betadine. After that, the procedure. We have 2 positions, lateral and sitting position. Lateral position is an accurate position, but it is technically little difficult. Sitting position is technically little easier, but it is not an accurate position. After that, we set approaches. We have midline, paramidline and Taylor's approach. After that, conformation. How we will conform the spinal space? Looking for the free flow of CSF. Okay. Then complication. Most common complications are PDPH, shivering, urinary retention, high spinal and total spinal are severe, but it is rare. That are the most common complication in spinal anesthesia, and nausea, vomiting also. That's it for today. Thank you for watching my class.